Hi, Martin. Hi, Lillian.
Hi, Millicent. How are you?
I'm fine. I've joined early just to make sure that
Yeah,
I'm okay.
that's perfect. I have seen people
Yes.
have that I'm here with Martin, so we will be here
Okay.
without any technical issues.
Oh, okay. 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 Thank you very much. I think I should be fine today. I haven't
Okay,
even got home. I've just had to stop midway so that I
okay.
don't get late. Yes, I just had to stop midway. I figured out I won't get home by the time the meeting is starting.
That is fine. That's perfect. I can see members are logging in.
Oh, very good. That's
Yeah,
exciting.
yeah.
Okay, thanks.
Okay.
So you let us know when there's quorum, when we
Okay.
can start.
All right.
Then it's good to also make sure Dr. Okaka is here as soon as possible so that when we start, we can be able to flow.
Yeah, actually, I've just shared with him the panelist link so that he can
Okay.
log in. Let me just follow up with him.
Please follow up because the
Yeah.
speaker should log in early.
Okay.
Yeah, thanks.
All right. I unmute her.
Hello. Good afternoon, evening. Can you hear me? Hello.
Hello, Dr. Okaka. How are you?
Hello.
Yes, just checking to see
Good
you
evening, all.
can hear me.
Yes, we can hear you.
Okay, thanks. KHF team, I'll wait on your guidance then.
Okay, we'll guide you. Thanks. Good evening, all. Good evening, colleagues. Welcome to the webinar on exploring social health authority. My name is Millicent Olulo. I'm the regional director for Farm Access, focusing on the Safe Care Quality Program. And I also dabble as the Health Regulations Quality and Standards Chair. I want to welcome all of us in this webinar and really appreciate. Thank you for joining this webinar. We are happy to invite you and we are happy to have you actually attend this webinar. I can see we already have 40 packs on board. We really appreciate that you could join us in this very good conversation. This is one among the many discussions that we'll be having every month. And we are happy to be able to bring in topics that are really relating to our situation. And as we all know, the social health insurance and all the work around the SHIF and SHA is really critical at this point. So we hope that this webinar will provide a comprehensive look at the SHA in Kenya. We all agree that we are in a transition from NHIF and to the proposed authority. We are happy to review and share some insights on the new Health Act, the regulations, the benefit package, and just to broaden our understanding on the journey towards universal healthcare coverage. We also request that should you have some questions, please feel free to send on the chat. We'll be able to address them. And the ones that will not be able to address, will be able to share an email on the chat as well that we can be able to forward the questions to. Welcome once again. I can see we have more participants joining. And without taking much time, I would like to invite our speaker for today, who is really quite experienced in terms of health financing and is the Vice Chair of Health Financing Committee, Dr. Dennis Okaka. Dr. Dennis, how are you this evening?
I'm very well, thank you, Millicent.
Yes, thank you very much. Karibu sana. And I would just like to give you the floor to introduce yourself and then to set us going, because we hope to finish exactly by 6. Thank you very much. Looking forward to very interesting discussion. It should be interactive. Participants, you're very encouraged to send questions in the chat and to engage as much as possible. Thank you very much. Over to you, Dr. Dennis.
Thank you, Millicent. So thank you to the teams who've joined. Thank you to KHF for this. You will pardon me in the process of recovering from a cold. So every few seconds, I might mute myself just to cough, literally. So you will forgive me for that. Yes, and so here we are. When we began this discussion on the webinar, we had hoped to have a representative from government, whichever body, either the healthcare financing team from MOH or the Social Health Authority, to then speak to their perspective on where everything is going. Unfortunately, none of them was able to confirm. So I was called in to speak from the, I don't want to call it private sector, because I'm here as a Kenyan, someone who's gone through the acts and who's particularly interested in what the laws mean, not just for us as private sector, but for me as a Kenyan with Kenyan roots and who's going to be in that system. So Okaka is my name. I am a Vice Chair for Healthcare Financing Committee at KHF. And I also support, a member of the Managed Healthcare Committee, the Kenya Medical Association. So I'll quickly take you through will then be what is, where did we start from, where did we get to, and where are we at now? And then hopefully we'll be able to open up and have time for questions, because I'm sure that's where we'll get true content. If it's okay with Millicent, may I proceed? And confirm that I'm on full screen.
I confirm, please proceed.
Okay.
Yes, you are.
Thank you. So we all know where this began. This was back in November, end of last year, where we then had 4 acts, I don't want to say thrown at us, but then all enacted at the same time. The Primary Healthcare Act, the FIF Act, the Digital Health Act, and the Social Health Insurance Act. So 4 acts that then are generally going to determine how we work for the next foreseeable future. So the Primary Health Act, I guess this is to rework the healthcare facilities to then design themselves into a hub and spoke model that would be called primary care networks, that then would have facilities in quasi-partnerships. So with a level 4 hospital as a hub, and then the surrounding, geographically surrounding level 1 to 3 facilities acting as spokes, tackling primary healthcare as defined here, and then referring people to the level 4 facility. So this should be level 2 and 3. Sorry for that. Then your community health unit was then defined as your level 1 facility. It's not an actual facility. It's a group of 1,000 households, and every household estimated to have 5 people. So 5,000 people would be in a community health unit served by, I think, a single community health promoter, and then a number of other practitioners. It wasn't very well defined. But then at the head of this primary care network, you would have a family medicine practitioner. So practitioners of family medicine with a team running every primary care network. So that's how healthcare is envisioned to be structured. How we get to that, we will figure it out. How private healthcare facilities are then going to also partner, because what quickly is coming out is private healthcare facilities are already 56, maybe 55% of healthcare facilities in the country. So how this will be structured is still something that's out for debate. And I think this was a presentation from the Ministry of Health on the same thing. I will share these slides with you. Don't stress with pictures. All these are in public domain, and public being at least the meetings we've been able to attend. So this is just a more detailed representation of the same thing. Then a Digital Health Act was again enacted that created a digital health agency. We've already seen the appointment of the board chair for this. This digital health agency was supposed to be in charge, or is supposed to be in charge of what they're calling a CHIS, Comprehensive Integrated Health Information System, which will receive data from 2 specific places. So a national health data bank and a county, and the 47 county health data banks. So what is expected to happen? All hospitals, public, private, doesn't matter, will be feeding data into their respective health data banks in the counties. So whichever county you're in, there's somebody working on this. They're already working on interoperability standards. And then all the primary care networks will again be feeding. There'll be a lot of duplication, but I hope they'll figure that out. And then the level 6 hospitals and any national databases would feed into the National Health Data Bank. And then these 2 combined will form the CHIS. You must have seen, if you're keen enough, some money has already been set aside in after the finance, the budget reading last week. So some money was actually set aside for this. It wasn't put under the health bracket, but money is already set aside to complete this work that is ongoing at Konza City. Yes, as you were informed, this would be done at Konza City. And this is how the entire ecosystem looks like. Again, I just tried to simplify it. I will share this with you. The idea is then to get everyone communicating on one system. Then the third act that was then brought, so I've ignored the Facility Improvement Fund Act. That is focusing mainly on public healthcare facilities. And then the fourth act would be the Social Health Insurance Act, which established the Social Health Authority here, with the people you've seen appointed. And this Social Health Authority is supposed to receive money from Parliament and from contributions that will then be run via the three funds we have all heard of. So the Social Health Insurance Fund, the SHIF, which would receive money from your contributions and from Parliament, and then the ECCIF and the Primary Healthcare Fund. Then there are regulations that are then going to determine how the Social Health Authority will work. So Dispute Resolution Tribunal and general regulations, which establish a panel that is supposed to advise on benefits. And this panel has not yet been set up, but we have benefits already shared with us. And so, yeah, we work with what we have. So the Primary Health Fund, as you can see here, is mainly going to purchase primary healthcare facility services as defined in the Primary Healthcare Act. And so this will only be active at your level 1 to 3 facilities and at level 4s that are designated as hubs. Remember the hub and spoke model, so the hubs. And then your ECCIF would be active for every single facility, especially the emergency aspects. And then your chronic and critical illness will only be at level 4, 5, and 6 facilities. Chronic being your chronic illnesses after exhaustion of your SHIF, and then your critical illness, your ICU, your HDU kind of care. And then your SHIF is essentially what your NHIF was. So I call it NHIF on steroids, that then just pays for every other care. So these were the benefits that then were shared with us. These benefits were initially shared with different groups of providers. I'm sure some of you were part of them. We gave proposals. Some were taken, some were ignored. Then this is what has finally been shared. And I know we had a meeting today in the morning. I hope KHF team should have been there to then socialize the feedback back to government. So I will quickly rush through this because, again, the document you all have. So the Primary Healthcare Fund, we said it will only give you level 1 to 3 services, period. So your level 1 then becomes your level 1 to 3 or 2, 3, and maybe a few of level 4. So your outpatient care services, that will be a capitation at 900 shillings per annum. This was particularly dicey. What they are saying is this: everybody will register with a facility. You, me, anyone, your children, your dependents, whoever it is, will register with a facility. And at the point they register, that facility is liable to be given 900 shillings every year to take care of all your outpatient care. Sorry. Now, this 900 shillings, the expectation is, of course, not everyone will access the care. Not everyone would need it at the same level. And then this 900 shillings will be paid out per quarter. So 900 divided by 4, 225 shillings. Yeah, 225 shillings per quarter. will be paid out to the facilities for your outpatient care. And then the last thing is they will do a 90-10 split. This number is still not cast in stone. 90% of the money will be paid up front. So 90% of the 225 shillings will be paid immediately. The 10%, 22 shillings and 50 cents, will be held back by SHA and will only be paid out for portability, meaning you got ill, you traveled and you got ill and you want to seek healthcare outside your station, your registered hospital. So you travel, you go home, rural areas and everything, or there's an emergency and you need to seek care outside that. And this is the important bit, the 10% will also be on a pay for performance, meaning the ministry will come up with quality metrics to say, you have performed well as an institution, and so we will pay you this 10%, or you have performed poorly, and so we will deny you the 10%, so the 90 shillings per year. So you'll only get paid 810. The hope is the incentive will be for you to perform better. These quality metrics are going to be defined in an upcoming bill that is called the Quality of Care Bill. We have not seen this bill. Maybe someone in the room is deep state and has seen it, so we are not yet privy to this bill, but we know the bill is in the process of being made, and as soon as it's ready, they will share it with us. I know I've taken a bit of time, but I hope that explains this single slide. Then maternity, again, another dicey discussion. A normal delivery was priced at 11,000 will be paid for out of initially the PHF, and the cesarean at 32,000. This number was reduced from what they shared with us. Initially, it was 34,000 shillings. And of course, sorry for that. And of course, our concern is based on what we think or what we know that are rates for specialists and medical officers. Government is essentially telling you we only want healthcare paid for or cesarean sections done by medical officers, and will not be able to afford any specialists doing cesarean sections. To me, that's what our government was telling us. But these are the rates that, again, they have shared with us. And then we have screening of precancerous lesions. The information we got was that this was not very, okay, what we could tell was this was not very scientific. If you can notice, they are only starting prostate cancer screening at 55. Recommendations start at 40 years for Black men. And so we have a 15-year gap that's missing, that will be missed out. Colon cancer screening, again, another concern. They only wanted to do it for men, not for women. Someone has argued that maybe colon cancer is more common in males. I think women have colons too. But yeah, so there's a lot that's still not clear with this. And then your optical care, they were giving 935 shillings with a limit of 1,000 shillings per household per year. So you'll have to choose who in your household gets spectacles. The rest will pay for themselves. Keeping in mind that refractive errors are very commonly genetic. So if you typically find a family, more people have refractive errors than not. And so there's, again, questionable. And NEO is end of life services, which will be paid at 500 shillings per day up to 5 days at facilities where that is available. And then your inpatient care, because this is only level 1 to 3 facilities. If you're admitted in level 3 facilities, they'll be paid per diem at 2,400 shillings up to 50 days. Then your shift goes back to what, as we said, NHIF is typically like. So your outpatient will be a fixed fee for service. Remember, your first point of care will be your level 1, 2, and 3. So you can't take yourself to a level 4 hospital, no matter what, unless it's an accident, an emergency. So if you're ill, you will take yourself to a level 1, 2, or 3 facility. They review you, and if you need referral, you're sent to a level 4, 5, or 6, and then your shift takes over, and they will pay 2,000 shillings as a fixed fee for service for the care at 4 visits per year per person. So this will only kick in after you've been referred. So keep that in mind. If you're admitted at between level 4 and 6, these are the fees that would be paid per day. So between 3,500 and 5,000 shillings with a limit of up to 50 days. So far, inpatient is up to 100 days per household. Now, this is again another tricky thing. Per household just makes things murky. Essentially what they are saying, if you are 2 contributors, then one is the principal, quote unquote, why is another the dependent and not getting full benefits, yet they're still paying 2.75% regardless. So that's probably something we need to question. Maternity at levels 4 to 6, same rates within shift. And then they introduced dialysis. Previously it was 9,500, has gone to 10,650 with 3 sessions a week. And peritoneal dialysis paid for at 180K a month. Then mental wellness benefit, previously not very clear before. They have these different rates. So your outpatient, your inpatient, which is per diem, almost similar rates to the rest. And then drug and substance abuse. So your detox at 14,000, rehabilitation at 125,000. Surgery had a long list that probably we won't have time to go through, but they had fixed fees for service for quite a number of surgeries based on feedback they say they had received from the different specialties. And I think you'll have access to that document. Oncology, maybe what stood out for oncology was now for the first time, they will start paying for testing. It wasn't always very clear. So testing was not paid for. Now tests will be paid for with an upper limit of 100,000 shillings. Then the treatment at these different rates at the level 4 to 6 facilities. So radiotherapy, brachy, chemo, and the PET scans and MRIs as needed. Imaging, the government was concerned, or people working with SHA are concerned about misuse of imaging, and a lot of them are speaking to their previous experience with NHIF. And so they have put quite a bit of restrictions on this. Your MRIs or CT scans at 2 images per household. So if you are in an accident with your family, we know that typically happens. People travel a lot. You will have to choose who gets what. I don't know how that will work. And then they've restricted the diseases or the classes of diseases that they would reimburse for. And then a third restriction is what they're calling specialized imaging. So your fluoroscopy, mammography, which is for breast cancer screening mostly, your echo, your EEGs, and Doppler ultrasounds have been restricted to government hospitals only. We tried to challenge this. There's still a lot of discussion. I hope this was brought up today. A good example would be if you have hypertension and you need to get an echo, you're admitted to one facility. Then if it's a private facility, you have to go leave and be transported to a government facility to get your echocardiogram done, then brought back. You know, it's not sensible. And so I hope these are limitations they intend to change. Pharmacy was given, this is a pharmacy outpatient benefit for chronic disease. And they mention a chronic disease registry, meaning we will have to set up a chronic disease registry. And then the persons registered in it will be allowed to access drugs at 5,000 shillings per person per year for these diseases. These same people would also access specialized labs at 5,000 shillings per person, again for the same diseases. We spoke to mortuary again. And one thing I think I missed out, for the specialized labs, they are only going to contract public facilities, faith-based facilities, and independent labs. They're not going to use private labs within private hospitals. So I know they took their time to mention this, so there's something they're targeting. So they did not mention hospitals or private hospitals. So only public facilities, faith-based and independent contracted laboratories. Then the final fund before we open up for questions was the emergency fund. This is straightforward. We are going to set up an ambulance, national ambulance call center. So anyone who has ambulances will have to register them and hand over their management to this center, which will be equipped with professionals, as they said, who will be managing transfers and evacuations. Prices have been given, set within 25 kilometers and beyond 25 at different rates. This will be accessible by all Kenyans. Of course, the hope is they will outsource some of the services to consortia of providers per region. So instead of having different people, different regions, the hope is people will consolidate themselves into single provider. So another call for partnership. Your A&D, your accidents they have gone through each and every potential class of emergencies. And what they've given is the first number is a number for investigation, the maximum limit. The second is a maximum limit for treatment. So number one is cardiac and pulmonary arrest. They would pay 5,000 for investigating and up to 98,000 for treatment. Number four is altered level of consciousness. At number four here, they will pay more to investigate, which is 12,000, and they will pay 8,000 to treat. So, and it goes on down the list. So I've matched the numbers to the specific reimbursable amounts. This will only be up to 24 hours. The assumption is beyond 24 hours, it's no longer an emergency, then you are switched to SHIF, which is supposed to take care of the costs. ICU, again, numbers were lowered from what we were shown before. The previous ICU was 42,000, and now it's down to 35, and HDOs, I think 11,000, now back to 10,000. And then palliative care at 5,000 shillings a day. Of note, this is only up to 14 or 10 days. Above that, they expect co-payment to take over. Chronic illnesses, I think we had spoken to this, so it's the same tariffs for shift. So your 5,000 lab, your 5,000 pharmacy, specialized pharmacy, and what have you. Then assistive devices, again, another contentious thing. They had restricted this to government hospitals only. And then they have given a limit of 1 device per household per year. So if 2 of you again are in an accident and need crutches for any reason, it's usually temporary, hopefully, then only 1 of you would get that benefit. So again, point for concern. Now, this is the entire package. I've tried to distill it as quick as possible. We had the finance bill also last week. What we noticed was we expected a lot more money would be put into healthcare than ever before. Sadly, that is not true. Healthcare has received a cut of this 12, 13 billion. So we received 142 billion as a healthcare sector last financial year. Now they've cut it down to 127. With the 2 funds, which is PHF and ECCIF, only receiving 6 billion. So I don't know how the government intends to run the 6 billion for 55 million Kenyans. I don't know. I'm not saying maybe they have a plan, we don't know. Maybe they will borrow, but that money that has been allocated, this is exactly what has been allocated. Even if you were to do a 900, just the what is it? 900 times 55. That's 4.9 billion. So even just the primary care, the 900 capitation fee, what we have as 4.1 billion is not enough for the 900 they intend to pay as capitation. So somebody is not telling us something, and ECCIF is only 2 billion for the whole country. Free maternity care was included in this list. As we understood, Linda Mama had been suspended, but they still have vote for free maternity care. But even this has been reduced from 4.1 billion in the previous year to 2 billion now. Now, we don't know where this is, whether this is part of primary healthcare fund and why this needs to be put separately. We don't have the explanations for this. And that is where we are at now. The information we had is that registration will begin on the 21st, and somebody has said the president will be member number 1 registered, and we have different information coming to us. We were initially told that everyone would have to register. Of course, that's what the regulations say, that SHA will have to register everyone afresh, including biometrics for everyone above 7 years of age. But the CS mentioned during a TV interview that we will find ways of transferring people from NHIF, and would, there will be ways to make the transfer of data simple so that not everyone has to register afresh. It still doesn't mean you're out of the woods. It just means we've saved potential 20%. There's still 55 million Kenyans, or 80% of the 55 million, whom we still have to figure out how to register. Yes, I hope I've stimulated enough questions. There's a lot we don't know, and there's a lot that hasn't been confirmed. I would suspect that was why it was hard to get someone from the government side to join us, because then they will not be able to speak authoritatively on some of the things. So that's where we're at. We're all waiting to see what will happen. Back to you, Millicent. I think we have time to do questions. Yes, plenty of time.
Yes, thank you very much, Dr. Okaka, for that very well presented overview, and even the details we really, really appreciate. And you are right that a lot is still work in progress, especially from the government, and that's why they were not confident enough to answer or to be able to join us for some questions. You also alluded to the quality of care bill. I've been part of it since we started working on it. And we hope that it can be shared. The zero draft can be shared for participation soon. So thank you very much. Thank you also to the participants who joined us as we were continuing. And I can see quite a lot of questions, which I hope you can address some. So I could maybe pose like 3 questions.
Yes,
In
please,
batches
go on.
of 3 questions, yes. So NHIF used to cover public healthcare workers comprehensively, whether in public facilities or private facilities, depending on the job groups. Will that arrangement continue in the new outfit, noting that public healthcare workers are the first-line defense participants in protecting the society from diseases? The second question, if they will transfer data from the current NHIF, how will we choose the capitation facilities? Then the third question, what is the role of hospitals in the registration? I think you can take that before we move to the next batch.
Okay, so for the new, I don't know what the term, there was a term they used to use for them, those schemes. So your civil servant scheme, your,
It
at
was
one point,
special
police.
benefit packages.
Yes. One time the police were in your Linda Mama, right? So all of them have been stopped. As of November, December, they were terminated, and they were just being let to run out their course because they are renewable annually. So they were being let to run out their course, and none of them will be renewed. So civil servants, what is not clear, because I understand from the civil servant scheme, medical allowances were taken from your pay and sent to NHIF as a risk pool. Now, if that has been stopped, what I expect civil servants to do before they join us on the streets is to demand for their medical allowances back to their pay slips, because those medical allowances are still theirs. It should be back on your pay slip, and you should demand that. And then what we think will happen, and the discussions we had with a few private health insurers, is that potentially you would have civil servants would want to negotiate if they want a special cover with any other private health insurer. Now, there's nobody who's going to do that kind of risk pool again. So civil servant scheme, gone. The second question was on, remind me, was on registration. Millicent?
Yes, the second question of if they will transfer data from the current NHIF,
Yes.
how will we choose the capitation facilities?
Yes. So
maybe just before you go on, good to mention they are not special schemes, they are called managed schemes. And
yes,
an
managed
example
schemes.
is the likes of the CARO for the retired civil servants. They've been transitioned to Old Mutual. Thank you.
Okay, so thank you for that. So the CARO seems to have already found a deal and negotiated something different. Civil servants, the ball is in your court. First, ask for the money back. It should go back to your payslips. Let no one lie to you. And then you can negotiate something unique. And then for the capitation, if you've seen, we are being told to go and look at sha.go.ke, which has an app. They're saying they will use information from the eCitizen app. If I've tried the eCitizen app, it asks for a facial recognition of fingerprints, which can only be done because I've tried to have it read my fingerprints. It won't. It needs assistance. So I think it needs activation, the initial activation at a Huduma center. And then that app will be open and I'd be able to put in, my details should be there and I should be able to transfer them and choose a center. So this has not been done and it's not clear. And, even when they say the data would be transferred from NHIF, I tried immediately, but that was the restriction on the app, on the eCitizen app, the new fancy one that has there's a camera that asks you to put your 4 fingers and then it reads the fingerprint on them. So the app still needs activation at a Huduma center. So I guess hopefully they'll figure that out. And then there's another question on registration. Melissa.
What is the role of hospitals in the registration?
Okay, yes. So the announcement was this, that this registration will be done at public hospitals with the 100,000 community health promoters and at Huduma centers across the country. So 5,000 public hospitals in Kenya, give or take, 100,000 community health promoters, give or take, and there are around 50 Huduma centers. Those are the only facilities that will be doing initial registration. They have not announced any private healthcare facilities to be allowed to do this. Again, reasons are best known to them. To me, it would make sense to open it up to the extra 7,000 facilities that the private hospitals are able to. And you already, quite a number of them already have some infrastructure in the form of NHIF offices. So the ball is in their court. We are waiting to see what that means. No other information.
Okay, thank you very much, Dr. Okaka. So the next question is, what packages are offered for the diagnostic treatments for chronic illnesses like cancer? Then what performance matrix formula will be used to determine the 10% capitation settlement to primary healthcare facilities? So I think the other one has been addressed. Thank you very much, Dr. Gakombe. Our chair is here. The police, teachers, counties, etc. will have to make alternative arrangements. They can insure elsewhere or run occupational schemes. Yes. So please address those 2 questions. Then I would want to encourage us for any questions that we may not be able to exhaustively answer. We'll share an email that you'll be able to forward those questions and we'll be able to respond to them. Thank you.
Thanks again. The first one was on chronic illness diagnostics. The only changes we have seen are now that there's a provision for diagnostics and screening and follow-up of chronic illnesses, which was not there before. So diabetes, hypertension, any other chronic illnesses should be covered, even the diagnostics. Cancer was previously not covered. Now we have your H&D, your immunohistochemistry. Hopefully, no one mentioned genetic testing, but yeah, fish, so in situ hybridization is covered to a limit of 100,000 shillings. So your diagnostics for oncology are up to 100,000. So your HND, IHC, ISH testing, and then your chronic illnesses are under the specific benefit packages for SHIF and ECCIF. So those are covered. Whether the money will be there is a different thing, but the benefit package states that those will be covered. And then the quality metrics to be used, as I mentioned, Millicent is deep state. I'm happy to hear that. She's part of the team that's working on the bill that then will be shared out to us to look through and participate and say these metrics either make sense or not. During the discussions, though, one of the metrics that did come up was aspect of referrals. And referrals in this way. So if you're in a level 2 or 3 facility and you're receiving capitation, the temptation they were saying would be for you to refer all your patients to level 4 because you've already received the money. So if you're referring, then you're not spending money, the money that you already have. So that will definitely be a quality metric they would want to look at. What is not clear is whether, how the metrics will then be investigated, because you could be having a higher referral rate either by virtue of your geographic position or the epidemics or endemics in your region, some other factors. So but the feedback we got was then this will be discussed and this will be shared out and they will consider all that. Any other question, Millicent, that we haven't tackled?
Yes, thank you very much. I think there was a question on facility and panelment. And maybe good to mention, I still see there are quite a lot of questions and comments. What level of digitization is required at the facility? Then there's an email that we have shared with you. Please kindly share the questions and concerns on this email. It's there on the chat, tafadhali. Thank you very much, Dr. Gakombe. You have commented for performance matrix. I believe we shall use the Kenya quality model, which shall properly be anchored in law through the quality bill. Safe Care, COSASA, JCI, and other international accreditation will be considered and given an equivalent similar to what Council for Higher Education does for external qualification. Then I see other questions still streaming in, but I just want to now give thank you very much, participants. I really, really appreciate that we could have this conversation, which is quite important. I want to give an opportunity to our CEO. I realize also our CEO has joined, then he will also give an opportunity to Dr. Gakombe, our chairman, to be able to even maybe just allude to a question and just say something. Dr. Tim Theuri, over to you, please.
Thank you so much. I'd like to thank Okaka for his very well summarized presentation that has brought out the essence of SHA, and to all our attendees, asanteni sana. On my end, I wouldn't belabor what Okaka has said. I wouldn't have said it any better. Possibly an update. Today there was a benefits package and tariffs meeting. And in our submissions, we pointed out a few things. One, being for the primary healthcare fund, where we pointed out that most of the level 2 and level 3 facilities may not be 24-hour facilities. So we may need to relook the referral mechanisms at that level. The other one was on the compensation mechanism, which is basically on capitation. The 900 shillings that Dr. Okaka has pointed out, it's coming to about 75 shillings per month. And with that, the capitation amount has gone down. Yet the proposed number of beneficiaries will definitely increase, and consequently the disease burden. So that amount we suggested about 1,500. And this is to be paid at the beginning of the capitation cycle, and as opposed to what the current proposals say, which is at the end of the capitation cycle. That would mean, if it goes as it is right now, private healthcare insurers would underwrite health during that period. And since all of that money is coming from the exchequer, it is important that they pay first and then we do the services. The second update is on co-payments for the ECCIF and the SHIF. And that, from what we saw, has been taken positively, the allowance for co-payment. And the other one was on the dental and optical services that have since been included, but those will basically be for government facilities. Validation will possibly happen on Thursday and gazettement on Friday if all goes as they have planned. Dialysis was also another issue that was mentioned, as well as a payment for CT scans and compensation for beds rebates at the level 4, 5, and 6. The proposal is to move them from 2,400 to 2,500 for level 3, for level 2, and then about 3,400 for level 4, 5,000 for the next level, and 6,000 for level 6. Those are the proposals we gave. So they've said they will relook at those, and on Thursday we will hear what the actuaries have decided on. The other thing is they gave an indication that management of claims will maybe first happen in-house, and then as they move down the road, onboarding of claims managers will happen, as has been envisioned in the law. So those are the updates from our end. We are following up on most of the issues on e-teams, if I'm to mention that. And at this point, I'd like to welcome Dr. Gakombe for his remarks and any updates on his end. Thank you.
Thank you, Tim, and Millicent and Okaka. In the interest of time, I'll not belabor everything that has been said. I want to thank Okaka and the KHF Secretariat for organizing this, and to thank you all for attending. As I put in the chat, we are going through a season of change in the healthcare, quite unlike what has happened for a while, maybe only compared to the time of independence. And we'll need all of you, all hands on deck, to negotiate our way through those changes. So keeps the proposals coming, keeps the ideas coming. The KHF team will pick them up and will then engage at various levels. I know the associations are engaged, Rural, RUFA, CAF, KHF is engaged, KEPSA is engaged, and we have to keep proposing the changes that we'll want. We may not win all of them, but there is no other way to win except to stay engaged and to continue to propose changes that will improve what is being suggested and make it easier for providers to thrive in that new environment and give access to Kenyans who need care. So asanteni, you have the email. We are available and willing to serve you. Thank you and have a good evening.
Good evening, Chair. Good evening, all. Thank you very much. I see a request for the presentation. Dr. Okaka, I believe you'll be kind enough to share with us the presentation so that we can share with the, yes, we can share with the participants. Yes.
Okay, thank you.
Thank you very much, and looking forward to more conversations. Thank you. Have a good evening. Thank you so much, everyone.